Good afternoon, everyone, and welcome to another episode of Free Your Ass and Your Mind Will Follow. Again, I'm accompanied here today by Greg Taylor, the founder and president of Taylor for Life Incorporated, and we're here again to bring you guys some helpful information to help the community strive to be better and to perform optimally daily, to perform optimally all the time. And as you guys can see, I'm accompanied here with another special guest. We're here with Dr. Nina F. Miles Everett. She's Chief Medical Officer, Priority Partners Managed Care Organization, Johns Hopkins Health Plan, is a primary care trained internist in Maryland. She received her medical degree from Howard University College of Medicine. She has a passion for working to improve the health of underserved populations by addressing the social determinants of health. So, thank you both for being here. How are we doing today?
I'm doing fine, and I'm delighted to be here today. I see you as a valuable partner, so definitely want to have this conversation.
That's right, and I'm excited again, folks, to bring you another interesting person that is a pioneer in a field, and I consider her a leader in this domain of health wellness and addressing the social and economic disparities within our communities. And so, with Dr. Everett today, we're going to have a deep dive in something that I'm very passionate about, and that's is the understanding why our communities are plagued with so many chronic conditions and things like that. And then specifically with Dr. Everett, we're going to talk about the diabetes and the impact it has on population health. And so I want to start with that. And I know that's a huge subject, but I want to kind of break it down so our audience can understand when we talk about the impact of diabetes on population health.
Absolutely. And I will say that I'm an internist, so I take care of adult patients. So I don't see patients anymore. But as I was practicing in community health centers, we had tons and tons and tons of patients who were impacted by diabetes. And I saw that it was just bigger than what happened in that exam room. So the opportunity to transition from one patient at a time to population health really inspired me. And so that's why I'm here. People of color, Black and brown people, are disproportionately impacted by many chronic diseases, and diabetes is one of them. And you just see the devastating impact on the people it affects. It's the people, it's the family, and then society actually really loses if people don't have good health.
Yeah, and that's interesting. And I spent a year ending up in, I think, June the 30th of this year in the community, in some of the communities, the Spanish communities such as Capitol Heights, Fairmont Heights, District Heights, Seat Pleasant, all that. And I had the opportunity to interface with people and hear their stories. And we talk about identifying these chronic conditions within our communities, but the more you deep dive into understanding what's going on, you hear things like food insecurity, employment opportunity, the lack of employment opportunities, housing, and it goes on and on. And then in a couple to the people of color, you got the influx of Latinos needing help. And sometimes there's a communication barrier between them, but somehow, and lucky enough, we were able to understand their needs by the cell phone translation. All right. So,
Wow.
You got to adapt to address the needs of the people. And we identified roughly over that year, roughly about 1,200 participants that either had health issues like insurance, housing, food insecurity, the whole shebang. And so the question, Doc, I ask you, and I know this is not everything on your plate, but I understand that you, and I know that you specialize in looking at the social terms of health, but how do we get at prevention of diabetes without addressing these other disparities?
It's huge. As a matter of fact, we met because the state implemented a benefit for health choice beneficiaries, the diabetes prevention program. And so that is a whole educational program designed to prevent diabetes before it starts. Because again, if I go back to practicing in the exam room, I tell a patient, okay, you have now been diagnosed with diabetes. That means you need to change the way you live.
Mhm.
So I need you to eat more, maybe a diet that's more plant-based. Well, that assumes that you have housing, that you have electricity, that you have a safe place to store your food. I say you need to exercise. It means you need to have a playground, a park, or a safe place to go exercise. You need to have a grocery store that sells fresh produce. And so you realize it's so much more than just writing a prescription, because sometimes lifestyle changes by themselves won't cure diabetes, but it helps. But if you don't even have access to those things. So again, as I transition to working for a health plan, in my role as chief medical officer at Johns Hopkins Health Plan, we design programs that look at those other things that people may not think of as health. And so we do query our members when they first enroll to see whether or not housing is an issue. We do query them to see, like, what are the factors, what are the barriers to you getting your care, so that we can work to address those. Because if you don't have a place to live, you don't have a place to store your insulin. Like, it's so much bigger, and we have to think holistically about how to address it. And then here you are, you're in the community, talking to people hands-on. And so we try to develop community partners so that we make sure we hear the voice of our members, and that we design things that impact them, that meet the need, not what we think are the needs, but actually people who are out there. You're out there making networking and then having your classes and hearing what the real issues are. And we're interested in hearing about them so that we could address them.
That's a good point you make, and I'm glad that you, as a chief medical officer, are doing the due diligence of trying to understand the whole person, not just if they're considered pre-diabetic or diabetic or something like that, or other chronic conditions. Because, by the way, if most folks that we intake, and some of this lately, it's been 21 years old with pre-diabetic, not only with predisposed other metabolic disorders, weight challenges, and I'm not biased, but women that we assess 250, 300 pounds, and some as 395 pounds that we've seen in the last month or so. And so we look at that as incentives for us to dig deeper, like a garden per se, and I tell my coaches, we got to do a little tilling per se. It's just like a garden, a metaphor. If you want to understand what's going on at the surface, you got to dig down a little bit. And if you can relate that to the social determinants of health, those levels, and try not to dig too much, but dig a little bit so you can understand what's going on, and so you can develop programs. And because of these women, and we got some guys too that's up there in the weight and have challenges with managing weight. But then I say to my coaches, it's not so much what they're eating, it's what eating them. And so when we begin to dig down a little bit, and we find out that the stress factors come into face. And one of the ways to mitigate stress factors is you eat. And it's not necessarily the healthiest food. It's what you have available. Like you just said, Doc, that you assess whether or not a person has that readiness to change, but we're finding that people have low levels of motivation and confidence. And so how do we expect to facilitate change in population health when their motivation and their confidence have been depleted? You said something the other day to me, or the day, about your community, Chase.
Yeah, it's there's like these new signs being put up with like people giving out their number for like different diabetes equipment. So it says if you need equipment for diabetes, they're putting up their signs on all the different bus stops, and they say call this number. And it's just pretty prolific where I live at. And one of the things that I was gonna add on was what different factors personal to someone is making them end up in having diabetes.
I mean, it's so big, and both of you touched on so many things. Even when you talk about obesity in this country is rampant. The rates are going up. With more technology, we're sedentary. People are not even leaving their homes to go to work. People are just not out and active, and are not eating healthy. So obesity rates are increasing, and that's one of the things that predisposes someone to diabetes. So, and then you talked about stress. Stress increases a hormone called cortisol. Cortisol increases the sugar in your bloodstream. So many things are interconnected, and it's just so prevalent. Where I thought you were going with those signs, because those are people who do diabetic supplies. And so all of them are not reputable, but diabetes is very prevalent. So you throw your signs up everywhere, you're going to get a couple of people calling, and then you get their information, and then it turns out it's fraudulent. Because a lot of that could be done through your provider. And I always say that's sort of the safest way to go to vet things, because there's just so much separate and unrelated. There's just so many fraudulent people out there. And again, you referred to people not even understanding their condition. So we know that health literacy is very low. People don't understand. They don't ask questions when they go to the doctor, and they leave without an understanding of, like, what is diabetes? What am I supposed to do? And sometimes doctors, we don't take the time to check in and make sure people understand. So one of the things that I'm trying to figure out, I have this like grandiose plans to help everyone, but really to address health literacy and teach people what are the things I need to ask when I go to the doctor, so that when I leave that exam room, I understand what my medicine is, why I take it, when I take it, what happens if I miss a dose. Because I meet people all the time, and I asked a gentleman about his medicine, and he said, I don't know what the names are. I said, if there's something that you're putting in your mouth every day, you should know the name, you should know what it's for, you should know the potential side effects, because that's part of taking care of your health. But there's so many individual factors that we have to address. I think of it as like the patient, the provider, and then the community.
Yeah, so many tentacles. And one of the things I want to go back to you, Chase, on the question why you're seeing the proliferation of these signs in your community. You ever heard the term redlining?
Yeah.
And so if you have a vulnerable population there, somebody is looking to capitalize on it. And Doctor, you probably know the statistics as well as I do, but the state of Maryland, we roughly spend, and this is as of 2024, $4.9 billion on diabetes-related health care. 4.9, let's say $5 billion. And another $2.1 billion on addressing the related productivity loss. And so that's roughly about $7 billion. And I'm thinking about, wow, that's a whole lot of money. And I'm going to say something right here. I submitted a proposal to the Health Resource Commissioner last year for $1 million. $1 million a year for 5 years. All right. And but it was good. The team got excited. Senator Benson got excited because it's her district. And 7 months later, we get a call saying, unfortunately, your organization didn't make it. We had so many people apply. And I'm saying to myself, wait a minute. I laid the stats out in the proposal, $5 billion, and you cannot give us and hold us accountable, folks, for $1 million over a 5-year period of time. So that's $5 million. Hold us accountable for facilitating change in the community. But yet you're going to spend $5 billion. Where's the governor at? Is he paying attention to what's going on? And I'll tell you another thing is the governor of Westmore is doing a great job. I was able to send him a letter to help a gentleman over in District Heights at 72 years old, stroke victim, confined to a wheelchair, right leg amputated, the right arm contracted, and his wife spends most of her time every day taking care of him. And so I was called in to assist, and I was able to facilitate some change. But I say, you know what? This is bigger than us. He's not getting any better. And so I wrote the governor, and the governor, thanks to the governor of Westmore, he sent additional resources to help her out. So kudos to her. He has an initiative now called Enough, No Child Left Behind, and it's addressing the success of school kids from grade school all the way up to graduation. But here's the challenge, and I'm working with a couple of partners on that, is looking at the statistics on there. We're finding that these kids, as one of the things we talked about, the drivers is not only just post-COVID, but, stress factors, mental health, behavior issues, it's substance abuse issues. It's the lack of, food, going to school hungry. It's the parents. I'll be honest, some of the parents, their challenges trying to find employment. If there's no employment, then what happened? The little Johnny or little Susan is sitting there looking at mom and dad trying to figure out how they're going to pay the bills. And so all these is a cumulative effect of what's going on in our community, and we call it that social determinants of health. But I would also say it's the political determinants of health. Now, Daniel Dawes wrote an excellent book that kind of lays it out, and he talked about structured racism. We see it every day being played out during the political election. We talk about the distribution of those resources and not making it to the place where we need to address that inequity in the communities. And also is the administrative powers of people in place that precludes those resources from getting down to the people who most need it. So that's a big challenge. And I don't see, Doc, a lot of people talking about that. And I know it requires someone to keep their eyes on the prize and those policies that are in place. I told the health officer, I'm not going to call his name, a week ago that, hey, wait a minute, we're not getting anywhere. We can identify these gaps in our community, but until we overlay the policies in place to see what will increase or close these gaps or what takes away from these gaps or strictly widen those gaps, we're not going to get anywhere. And so you can have a community needs assessment done, but at the end of the day, you got a good plan that you can share maybe with the state. But if you haven't aligned that with those political policies and legislation to see whether or not they are precursor of it or what. And so that's the thing I'm finding that as well. So I just, what's your thought on the funding part of it?
And I mean, you are so right, because you, and again, all of the different factors, but sort of the political, because again, we pay a lot of attention to what's happening at the top of the ballot, and we absolutely have to do that, but we have to get out and vote, and we have to educate ourselves about the local issues, the people who make decisions about where money go in our individual communities. Yes. So we can't we got to worry about the White House, absolutely, but we also have to look at the people who make those funding decisions.
Our local communities,
so that money can go where it's going and where it is the most good. So it's absolutely, there are structural things that the world is not designed to lead to healthy outcomes. And certainly Black and brown people are often disadvantaged. But again, we have to use our voices. We have to get people engaged. We have to get them out to vote. We have to get them aware of the issues that impact the health. Because again, you talked about the education. If you don't have a good education, you can't get a job. You don't have health insurance. You can't afford your medicine. So everything is so interconnected. But certainly, as you think about the priorities for your organization, everyone needs to set them in a way that we can divide and conquer, because it's so much bigger than just health. But then hospitals, health plans, the government needs to make sure that we connect with and support community organizations who are out there hands-on, touching, and making sure that we listen, we engage, and that we use, that's like another tool really to help us take care of, for me, it's members, but hospitals, the same thing.
Yeah, and that's true. And that's so what are you doing in terms of addressing the social determinants of health? How do you go about, from your perspective, look at it? Do you allocate resources, or do you look at it from a political or policies, or what? What do we do? I know that in your case, you have engaged our organization over the last several years, not only just being in your office, but being in the community, talking about these issues, and not just with diabetes, but women's health. And so that's something I know that's very dear to you. But is there anything else that you see that can facilitate change to get us to this movement? One of the things we're looking at is a movement, building a coalition, because we know that the administrative powers, and when I talk about administrative powers, that are the local council people, the could be the county exec, and all these people that are influencing where the distribution of the resources are going. But if we as a community begin to stand up and say, we're not going for that. I'll be honest, and I'm not going to call her name, but this council person was just elected to the council. And the first thing I saw is a 30-minute video of her. I shouldn't have said her because, but with her interviewing a cannabis shop. They're talking about the different cannabis types, the cost of it. And I'm saying, holy heck, we got people looking for work. Schools, kids are just going back to school. And that's our first priority, to think about cannabis. And then we say, well, when I talk to the political people, they say, well, Greg, we got to do that. But then I see all these tobacco shops. Those bills are being passed. And everywhere in the community, I see a tobacco shop. And trust me, they're not just selling tobacco. All right. So you got tobacco shops and you got liquor stores and stuff like that. And I'm saying, well, can we get a grocery store around here? If it's a co-op. But and so I think even if you took that $5 billion that I talked about, or the $7 billion, and look at, okay, maybe we can allocate some resources to the community to allow them to stand up their co-op stores, grocery stores. And we will finance it for the first year. And after that, you're on your own. But give the community a say in what's doing. And I'll tell you another thing, and all these things that did to me, but maternal health. That's a big one. I know that you talk about, and low birth rates of babies. And I saw where we're looking at proliferation of grant money to address maternal health. But then I scratch my head, Doc, and say, well, let's see. If mom can't get to have access to transportation to get to the doctor, that's going to impact the baby and the health of the baby. If mom can't get to a grocery store, if she don't have a car to get fresh produce and food, that's going to impact the baby's health. So how can you address maternal health if a community is delinquent in all these resources?
It's what keeps me up at night. I mean, you said a couple of things, if I could address. I mean, one, certainly as a physician, I know that I have access to people in rooms that other people in my community don't. So I just feel it's my obligation. I trained at Howard University. They train us. They think it's ingrained, and it's what I do. So that's the first thing. The second thing, you also talked about how do we as a health plan know the needs of our members. And so every member that comes into the health plan is surveyed. Like, what are the key things? Is it transportation? Is it food? And then we try to develop programs that address that. So transportation is a big one. So we set up a transportation system that we work in concert with the local health departments. Members reach out to the local health departments, and if they're not able to get transportation, then we actually fill that gap. Food insecurity, that's a big one. Again, if you're hungry, you're not thinking about your mammogram, you're not thinking about getting your kids immunized, you're thinking about how to put food in their mouth so they're not crying. So we have cupboards. I mean, we have cupboards around the state, and then we just do partnerships with people. You talked about how do we get the politicians to address the needs that are important to the community. It's called building coalitions, because there's so many different factors. Everybody can't do everything, but if we partner and you tackle this, you tackle this, you tackle this, and maybe you're the lead on this one thing and I can support that. And we have to do it consistently. We have to hold our elected officials accountable so that if they don't do what they stated, you got to be there watching what they're doing. And sometimes you have to be the voice of people who may not have the time or wherewithal to even check. Because again, I'm worried about feeding my kids. I may not be looking at the news or reading the newspaper to see how my local politicians are voting. But again, people who can have an obligation to be out there sharing information and then engaging people in the political system so that they use their vote to make change. Because, nothing changes overnight. It takes all of us working together. It's figuring out, again, where the target communities that have the highest need. So on a health plan level, that's what I do at work. But then outside of work, I'm engaged in other civic organizations that address different things, because we can't burn ourselves out because there's plenty of work to be done that doesn't have a solution tomorrow. So we also have to pace ourselves, but we have to bring people around. We need to show data. So like you said, you looked at zip codes. Where are the high poverty zip codes? Where should we target these interventions? And so find those community partners who can help achieve our goals. Again, this started with the diabetes prevention program, because you talk about all the dollars that we spend to address the side effects and the end stages of diabetes. If we can prevent it, then I would rather save money on prevention that you can then use for other stuff.
Yes.
Because we're paying on the back end. Let's put money on the front end and expose people to healthy lifestyles. Because when you know better, you do better. And some people don't know better because generations of people have lived one way or eaten one way, and they don't know anything else. So that's where
that's a big challenge, and that's one of the things that going back to tilling the garden, and I tell my coaches, and I always say, well, look, when you're working with the group, and we have normally groups of maybe 10 or 15 members, is to first understand their needs. That even though it's a group, you call them up once a week and identify their needs and understanding their why, and separating that from their emotional state, because there's a lot of emotional tied to it. And if you can kind of separate that again to show them that there's a way forward, just to follow the yellow brick road. Then you say, well, are you saying that this is possible? I can get a GED. I can go back to school. I can get employment. You said that I can grow my own food in these little canisters and containers. You saying that I can save money that way? You can teach your kids that apples are farmed. Are you sure? I don't know. It's been like this for 30 years. But then they begin to believe in themselves, in that increased motivation and confidence. And once that happens, it says, wait a minute, I don't have time for hypertension, diabetes, and I got to get this weight off me, because it's not only affecting my diabetes, but also putting stress on my kidney. And so, wait a minute, I got to get it with, because I got things to do. But again, it's that intrinsic motivation that began, but it requires taking time. And that's why with your expertise, we've been going in the community and having these health fairs, because raising the awareness of the community, because we can reach one, it's difficult. It's going to take a while to get to where we want to go. But if we have these community events and raise public awareness about these things and how they should be able to advocate for themselves. Seniors, this county is number 4 in the country for Alzheimer's. Prince George's County. And if you look at the Alzheimer's Association, they're saying that it's likely due to physical inactivity, social support, and poor diet. And so now we're leading the 4th in the country for Alzheimer's and dementia.
Yeah, I think there's something moving forward that a lot of people watching, a lot of people who are interested in these things should look into, to make sure that, we're getting all the vitamins, all the exercise, all the different things that we need to make sure that we're living and pushing as hard as we can.
Yeah, self-care. Self-care is very important. But again, I want to personally thank Dr. Nina Everett for coming in and being an expert and a pathfinder for those without a voice in our community. So I thank you for what you do, not only today, but every day.
Thank you kindly for having me today.
Yeah, all right. Thank you.